Hi, friends. You all must be shocked. It's the 9 o'clock on the dot, or wherever you are on the dot, and we're actually all starting. How could it be? Well, we couldn't contain our excitement. I can't contain my excitement because I get to be joined today by three wonderful people. The first and most important is the person who's jotting down all the info. I'd love to hand the mic, Julia, for you to say hi and maybe update people on how you're doing.
Hello, everyone. So nice to see you again. I'm very, very excited after yesterday, so there will be a lot of curtain teaching tonight. So,
Yes, you made the reveal. Kirtan is presenting another case. Kirtan, say hello, please.
Hi friends, good morning. Thanks for joining. I'm excited. I'm presenting case for the first time to my dear friend Andrew. We have talked so much over the phone, and I almost feel like he is living next door to me. So I'm finally excited to present case to him.
Andrew, that love. Look at
Mm.
that love.
Eh, yeah, I'm really excited. Curton presents his cases very, very intentionally and strategically, and I feel like he throws us a lot of bones kind of in his cases, which ultimately end up being very challenging. But I'm excited to be here today and fill in Prof. Rez's big shoes. Prof. Rez, if you're listening to this, I've been heckling you way too much in your clinical unknowns and whatnot, so joke's on me because now I need to be here and discuss. But looking forward, Robbie.
I couldn't be more thrilled to share the stage with you all and to the three people who are still on YouTube who may be irked by the prolonged introductions. Today is your day, my friends. We did this in a minute. I'm a little bit pressed for time because I have to leave early, but I want to make sure we get all the juice out of Kirtan's case. So this will be the last time we're concise. And I'll hand you the mic, Kirtan, to take it away.
Perfect. Well, I will say just one thing that today all the people who like purple color or violet color are going to love the VMR. That's it. So the title is Perplexing Pattern, and we'll start with the first aliquot. So we have a 29-year-old gentleman who has poorly controlled diabetes mellitus with last A1C of 14%, who is presenting with 1 week of pain and swelling in the left wrist and right knee. He denies prior similar symptoms, fevers, chills, chest pain, dyspnea, diarrhea, constipation, dysuria, hematuria, hematochezia, or rash. So all these were negative. In the ED, you go and see this young gentleman and you see that he's vitally stable, he's breathing well, he's looking good, and he tells you that apart from this joint pain in the left wrist and right knee, nothing else is bothering him. You take a quick look at those joints and you find that there is limitation in range of motion of both those joints, and they are a little bit swollen. You don't see any erythema. You get the basic set of labs and you see that the patient has neutrophilic glucocytosis of 14,000. ESR, CRP, both of them are elevated. In the ED itself, the synovial fluid analysis is obtained from both the joints actually, and both of them show around 30,000 to 40,000 WBCs with 96% polymorphs. And I will complete the teleport there.
Oh my gosh, what an explosive start. Andrew, just go for it. What are you thinking?
Yeah, really interesting start. We've kind of pondered inflammatory arthritis in the academy space quite a bit, and something I feel like we haven't talked about in terms of modifying the DDX for inflammatory arthritis is actually age. Maybe we've kind of done it subconsciously, but the first thing that stuck out to me is this is a very young guy coming in with what sounds like inflammatory arthritis. What I mean by inflammatory arthritis is we're seeing erythema, pain, swelling, and this is limiting the range of motion. And that whole space is separate from this non-inflammatory arthritis space where something is going on inside the joint that's more from degenerative causes or non-infectious, non-inflammatory causes, like just in run-of-the-mill osteoarthritis. So, when you're in the inflammatory arthritis space and you need to start counting the joints. Like, is it one joint involved? Is it 2 to 4 joints involved? Or is it 4+ joints involved? And I want to say Robbie actually uses different numbers than that. I'm thinking back, but basically the fewer joints that are involved, the more you need to start worrying about infectious and crystalline diseases. So here we see 2 joints, and I think Robbie has a really, really nice way of thinking about like monoarticular arthritis and the idea of septic versus crystalline disease. And I think I should just pass it off to you here, Robbie, because you're the one who's really like hammered those principles home. And I think there's no better way to think about the analysis for that in terms of the fluid studies and making sure that we know for sure the joint is not infected, which is going to be our first job. So, Robbie, is it a good place to pass off?
Oh, for sure. I'm actually going to pass it off to Rahul. Rahul, what do you want to know about what do you want to know about the synovial fluid? If not, Parisa can bail you out.
Yeah, thank you, Ravi. Thank you so much for the opportunity. First of all, I would call the lab and look for the gram stain as I learned from.
Yes. Outstanding.
Yeah,
Outstanding.
those
Outstanding.
would be first. Thanks.
Exactly right. See, you learned yesterday and you get to practice today. I'm so glad you're here. Thank you for joining us. And Rahul will tell you that the poor Rahul has had to have listen to me take him through a very challenging, grumpy microbiologist who was refusing to give him any more information. And I think that's the person you need today. Because Andrew, I love the way you took us to the fact that you're concerned this is an inflammatory arthritis and that you're outlining the tension between crystal and infection. And you actually pointed out a very subtle but important nuance, which is the age. And I think the age of the patient is crucial here because the probability of crystalline arthritis in somebody who's very young is exceedingly rare. Now, don't get me wrong, you can get hereditary forms of gout and you can get secondary forms of pseudogout that can affect younger people, but as a 29-year-old, for you to default to those diagnoses would be very, very risky. So the question is there any other autoimmune disease that we have to consider? And the answer is yes, but not now. Just to be able to park our destination for autoimmune diseases that cause oligoarthritis in younger patients are the spondyloarthropathies. So reactive arthritis is an example of that. And so that's going to be the competing differential diagnosis to the most important consideration, which is infection, infection, infection. And I would say that anytime that you have an oligoarthritis infection is your default diagnosis, and you start to say, okay, wait, if I don't find anything, maybe I'll start to think about crystalline disease in an older adult or spondyloarthropathy in a younger person. And I think here that momentum is to worry so much about infection, not just because of the patient's underlying diabetes, but also because of the patient's neutrophilic leukocytosis. And I think the question then becomes, well, how do we analyze the synovial data with the focus on infection? And I'm really curious, Andrew, like what is your mind doing with that information, given the pretest probability of infection? What happened to your mind when you saw that white count?
Yeah, I mean, I think the presence of systemic inflammation here, ignoring the synovial fluid count, is a bit concerning. Not just because our pretest probability for crystalline disease is low, just like ignoring that. I feel like in a young person who's otherwise healthy, that's very much a red flag, and we have to be worried about infection here. So I like Rahul's comment on getting the gram stain, also culturing the fluid, and kind of going down that path, and then asking that question, which it seems I'm not sure if we got the answer to. Are there crystals visualized in this person? Because if they're not crystals, then we're not reassured at all. And we need to start thinking about what infections can be doing this. And we can certainly talk about that. And maybe we should, Robbie, should we like start talking about what infections
Yeah, please go for it.
Yeah. So I think some ones that come to mind for oligoarticular arthritis, just because we have two joints involved here, are spirochetes. So syphilis can do this, and Lyme disease can do this. And then disseminated gonococcal infection is the other big one. And that can be very much polyarticular if it goes untreated. And usually you'll see like diffuse pustular skin lesion with that as well. And if this is just like really, really early in the disease, we're not yet seeing polyarticular involvement, and then it becomes polyarticular, then we have to broaden our infectious diseases basically to capture viral diseases. Some of this stuff can be reactive, although usually reactive arthritis is more oligoarticular, but just polyarticular kind of sterile inflammation can be seen, like parvovirus, hepatitis, viral hepatitis, etc. But I think probably in someone with diabetes, which we certainly need to layer on. If it has been very poorly controlled. If it's been poorly controlled since they've been very, very young, they're certainly at risk of just skin and soft tissue infection, and that can very easily seed into the blood and then subsequently into a joint. So if that's the case, then we're kind of just back square one, like monoarticular DDX, just like gram positive, gram negative, just routine stuff that can get through your skin. So I think if we don't see those things in the culture or in a blood culture, which we often talk about, do we need to get blood cultures in people suspected septic arthritis because it's overall pretty rare? I would say since there's a leukocytosis here, we probably should, would be my guess. And that may even capture stuff like disseminated gonococcal infection too, if those end up flipping positive. But yeah, I think like there's serologic testing for all that stuff. There's blood cultures. And then if all that pans out negative, viral testing could be entertained later on, I suppose.
Yeah, no, Andrew, I'm right there with you. I think that the very simplistic way of thinking through septic arthritis is to realize that most of the time there's an infection somewhere else that goes to the joint. And in all instances, especially including oligoarticular arthritis, there's hematogenous dissemination to the joint. And so really the main organisms that cause septic arthritis are organisms that commonly cause bacteremia, including staph and strep. And so I think that the yield of blood cultures in the average patient with monoarticular septic arthritis is about 50%, and that'll certainly be higher than more number of joints are affected. So really, like you don't really bat an eye and think about staph and strep, very, very common causes of septic arthritis. And the third most common cause is disseminated gonococcal infection. And you can remember that by realizing that the empiric treatment for septic arthritis, which this patient would likely receive quickly, is vancomycin to cover staph and strep, and then ceftriaxone to cover gonorrhea. And so you don't really need to think more about the microbiological causes beyond those three things at a first glance. Um, and that's, I think, where we're at right now, where there's no reason to dive deeper in this case than to think staph, strep, and gonorrhea. And then you might ask yourself, well, how do I get confirmation? And I think for staph and strep, the the synovial fluid culture only has a sensitivity of 70%. And so you try to increase your yield as much as possible by getting blood cultures, which gets you a little bit more. The best way to diagnose disseminated gonococcal infection is actually not through the disseminated aspect, but through where it was acquired. So the yield for synovial cultures for disseminated gonococcal infection is 50%, but the yield of the mucosal swab in the pharynx, rectum, penis, or gynecological tract, or vaginal swab, namely, is almost 100%. So what would I do for this person? I would get blood cultures. I would culture the fluid that we just obtained, and then I would also, if you want to be broad, you will swab every mucosal surface. If you want to be targeted and ask the patient about sexual history and sexual exposures, you risk the fact that the stigma associated with sexual activity may cloud the patient's answer to you. So I think in a situation like this where the stakes are very high, you might just consider empirically swabbing every site, which is tricky because patients may feel stigmatized by you, and so you have to figure out how to approach that balance with the patient in front of you. So I think practically speaking, blood cultures, swab every place the patient allows you to, mucosally for gonorrhea and chlamydia, and then empiric vancomycin, ceftriaxone. In parallel, I think, Andrew, we have to be careful not to get what's called the vortex effect of pain, where the patient's like saying it hurts here, it hurts here. You have to make sure the patient doesn't have an extra articular focus of infection. So if we miss a murmur here, that would be bad. If we miss a pulmonary focus or a GI focus, that would be bad and would delay our solving the problem. And I can imagine when somebody's in this much pain, you might miss a focus elsewhere. All right, I babbled a lot. Kirtan, what do you have next?
Perfect. So everything is going well. Let me tell you the second early quad. So at this point in time, the blood cultures were also obtained. Two sets of blood cultures were negative. There was no growth of crystals or organisms from the fluid. The gram stain of the fluid was also negative. The uric acid was normal on admission. It slightly went up during the subsequent 1 or 2 days. It was 7 or 8. And at that point in time, since nothing was growing, the rheumatology team thought that given the poorly controlled diabetes mellitus and high uric acid levels, it could be consistent with gout. So patient was sent home on prednisone, 40 milligrams, to complete 5 days course because two joints were involved, and they thought that it's the best to give prednisone rather than colchicine or NSAIDs. But however, patient returns 1 week later with worsening of the symptoms, and he didn't feel any improvement. So what is the worsening that he has noted? So the same joints, left wrist and right knee, same joints are involved, no other new joints are involved, but those joints are more swollen, more painful, and he noticed new swelling on the lateral aspect of the wrist. So his wrist was involved, but now he is seeing the clear bump on the left aspect of the wrist. And he has noticed the new violaceous rash, of which I will share the image. Other past medical history, so patient has diabetes mellitus. We are not sure whether it is type 1 or type 2 because we don't have the antibody testing. It was diagnosed 2 or 3 years ago, and patient was started on insulin, but he couldn't remember if he has been taking the appropriate doses. So he was telling me that sometimes he checks his sugars when it's above 200 or 300, he will take some units of insulin, otherwise he won't take it. So the compliance was not certain. No recent travels, smoking, alcohol, pets. And on examination, again, he looks unwell. First time he was looking all right, but this time he's looking unwell and he has severe pain in the left wrist. You find the fluctuance over the lateral aspect of the left wrist and you cannot identify the borders. So the whole lateral aspect seems boggy and swollen. And there is limitation in range of motion of both the joints. And I can also share the images. I have two images. This is the first image. Both of these rash are on the shins and they are not painful. And share the second image, which is more violaceous. And that also concludes the second record.
Very interesting. I think we should go back to the fluid results and the conclusion that was made. My understanding is the sensitivity of visualizing crystals for a crystalline disease is quite high, at least for gout. I think pseudo gout may be a little bit lower. So I, I think the call that this was gout may have been a little overzealous. This all depends on your pretest probability, but our pretest probability, I think, going into the next aliquot was pretty high for infection based off of the patient characteristics. But here we are. They're not getting better after their treatment, so I think we're kind of back to where we started. That this is probably some sort of infectious process of the joint, and now we need to figure out what it is. And it sounds like nothing is kind of grown from the fluid, which Robbie has already taught us earlier in the session that the sensitivity is not perfect for these organisms, particularly for gonococcal. And I don't know that rash. I've seen a couple of different photos of disseminated gonococcal uh, mediated rash, and I think it looks pretty similar to that. I see in the chat, it looks a little umbilicated. I don't know if that changes things, but I'm a little worried for that. I think we should get those swabs that Robbie mentioned. But Robbie, what do you think?
Yeah, I mean, I think ultimately, Andrew, you're seeing how difficult it is to come to a diagnosis in many situations with inflammatory arthritis, where you know that there's no test that's perfect that can clinch the diagnosis unless it is positive. And so there's many holes in the culture um, and many holes in the crystal and testing. And I think ultimately now you can reframe this case as a patient with worsening oligoarthritis who has a culture negative in multiple different locations, who then develops a skin clue. And I think it's really helpful that the vigilance to an extra-articular clue has helped us. And I think of all the things that you mentioned earlier, disseminated gonococcal infection is the one that fits most elegantly when you have a cutaneous focus. I will tell you, I was impressed. In patients with DGI, they often have pustular lesions that are hard to find. There's one, two, maybe three. The sheer burden of lesions that this person had was a tip off to keep the focus on that, of course, but also expand it to other things. And not just that the fact that the lesions weren't pustular, that they were really umbilicated and deep, um, pushed us to sort of entertain our full category of infectious causes of oligoarthritis. And for those of you in the CP Solvers Academy, just yesterday, we shared a schema that talked about all the possible infections. And so if you're thinking about them simplistically, There are pyogenic infections like staph and strep, and some gram negatives. There are atypical infections that include three big categories: gonorrhea, Lyme disease, and granulomatous infections. And then finally, there's intracellular organisms like virus, mycoplasma, and ureaplasma. So I think based on the umbilicated nature of those lesions, if you ask yourself, like, what kind of infectious category classically triggers the differential diagnosis of umbilicated lesions, and I would say it's typically can be viral like molluscum, but I think the most common category are granulomatous infections, which would fit very, very nicely with the notion that this patient has culture negative septic arthritis because those organisms are inherently culture negative. And that's where I think going back to the host is really key, and a reminder that patients with diabetes are at risk for a whole host of organisms that include staph and strep, but also extend to the whole family of granulomatous organisms. The rate of disseminated TB, the rate of disseminated cryptococcus, the rate of disseminated histoblasto is much, much, much higher in patients with diabetes. And so I think that this case now evolves to beyond the first pass workup, not not skipping over the fact that this could be culture negative pyogenic septic arthritis because the patient hasn't received vancomycin and ceftriaxone, but by virtue of the umbilicated lesions and the fact that the patient only has a modest leukocytosis in the synovial fluid, a feature characteristic of the atypical organisms gonorrhea, Lyme, and granulomatous infections. So I think my next step would be a very simplistic approach to granulomatous infections to make sure we're not missing them and recognize that most of them come from the lungs. So you'd be surprised how much progress you can make by getting cross-sectional imaging of even an asymptomatic patient in their lungs. But it would also be a good time to get an exposure history from the patient, knowing exactly where he lives, which I imagine is in the Chicago area, but Kirtan may be presenting a case that was referred to him. We never know. But also to remember that skin exposure is really, really key. And one of the most common granulomatous causes of a parallel cutaneous lesion and arthritis is sporothrix. So I think knowing exactly what he's doing and what his exposures are is going to be really, really key. But practically speaking, I think it's now time to layer on some vancomycin and ceftriaxone because it easily could be culture negative septic arthritis. And then asking yourselves, where has this person been? And where else is this disease? And then, of course, the final key question is, what is his immune status? Is diabetes the only immunocompromising condition, or is there something else going on? I've rambled a lot, Andrew. I'm curious if any other thoughts have come to your mind in the interim.
Yeah, I'm so happy you added more onto the umbilicated nature of the rash. That's not a space I've pondered very much, and I think that makes a lot of sense. And my understanding of many of the joint diseases for even disseminated endemic fungi like cocci, histo. I believe much of the joint stuff is all culture negative and all reactive. It's like an immunologic phenomenon that is purely reactive to what's going on elsewhere. So I don't know if you'll ever see anything inside of a joint in terms of specific staining and culture inside the joint if it's purely reactive. So I think in someone like this, again, we haven't clarified like the HIV status, as you've said, and many people have said in the chat. I think either way, probably the yields of our testing is going to be highest in those skin lesions because those skin lesions just look like they're containing organism. And sometimes it doesn't pan out. You can think of other spaces that doesn't work, like in histoplasmosis. If you're immunocompetent and you try and culture a lymph node, your immune system is working. So in one pathology thread I've read that really like the culture is not good for immunocompetent people in histoplasmosis because your immune system will have destroyed all of that stuff, and what you need instead is the stain, the silver stain, to look for the skeletons of the disease in terms of the lymph nodes. So it's just like when we're going down this road of how to diagnose like a fungal infection, I think it's just important to know like where do we expect this thing to be actually growing on culture, and if we don't expect it to be growing on culture, can we stain it with something like silver stain and visualize it in the absence of culture growth? And I think in that when we're thinking about those sorts of those caveats, I think probably going for one of these umbilicated lesions is going to be the highest yield thing. But yeah, I don't know in terms of acquisition, Robbie. I like the idea of like skin acquisition because it sounds like we got a pretty good review systems on this young gentleman, and and there's no pulmonary stuff. And it'd be surprising just for him not to have any sort of like fever of unknown origin, dry cough, like last couple of weeks. So I think the Sparthrix hypothesis is certainly a really good one, and a little bit more occupational history and kind of what this guy does for fun. But yeah, Kirtan, I'll pass it off to you unless Robbie, you have anything else.
Perfect. You guys are cruising along perfectly. I will give you all the data which you requested. So regarding his past medical history, he was like he hasn't been outside his home in last 2 or 3 months. He just stays at home. He works from home. He denied any kind of sexual encounters or anything. And at this point in time, the basic workup was often HIV, hepatitis, syphilis, urine gonorrhea, chlamydia. All of them were negative. But urine analysis did show 6 RBCs per high power field, and this was consistent for 2 or 3 US, which we obtained while he was in the hospital. No protein was noticed, specific gravity was okay, pH was okay, nothing grew from the urine either, and he denied dysuria or any kind of symptoms. But the UA showing RBCs was consistently present. What about his CBC this time? Because this is his second admission. So WBC now shows worsening. Now it's 23,000 with 90% polymorphs. Platelets are also elevated at 700,000. Hemoglobin is normal at 12. ESR elevated at 80. CRP also elevated at 50. And urine toxicology screen was also obtained, which was negative. And at this point in time, the dermatology team was consulted. They looked at the rash, and I will tell you the biopsy in the next result. I mean, next report. But they said that this clinically, it looks like either it's vascular in nature or it could be paniculitis in nature. And I will stop there.
Kirtan, if you happen to have it, did you have a rheumatoid factor on this patient?
Yes, good point. Yes, we did obtain rheumatoid factor, and it was unremarkable.
Got it. Robbie, do you want to start on this one?
How could I start when you're here, man? You're only here like once every millionth Friday. Go for it.
I think Kurtzon is throwing us a couple of different bones. One of some more non-specific, like platelet count of 702,000, just goes to show that there's some sort of reactive inflammatory process that's still going on. So basically, it's just making us sweat a little bit more because we need to figure out what's going on. It's not getting better, and I think same goes for the leukocytosis. The CRP and the ESR just confirm that we're dealing with something very inflammatory. And if you sometimes see an ESR greater than 100, people consider a very like niche DDX that usually just considers like giant cell arteritis, vasculitis, osteomyelitis, very, very inflammatory stuff. But we're not even at that threshold yet, so I don't think it really gives us anything. I asked about the rheumatoid factor just because that is almost like, if you send like an SPEP, you can get either monoclonal protein or polyclonal hypergamma globulinemia. That's like one of those globulins you can see if it's polyclonal or basically any sort of like chronic inflammatory process will drive a rheumatoid factor up. And if it gets very, very, very high, it's almost like a tip off to endocarditis, which is kind of what I was getting at with this because Robbie even brought up, are we missing something in terms of the origin of this living on the valves. And, when we start hearing about, are we about to get a biopsy showing vasculitis? I mean, that could all be reactive to endocarditis. So it's kind of interesting that the rheumatoid factor is negative. I don't think it strongly points us away from endocarditis, but if it was very high, I think it would have made us look at the heart a little bit more closely. The urine is interesting. It sounds like we have no confounding reason for these RBCs. So we're wondering if there's glomerular involvement from what's going on. And, when you start invoking glomerular nephritis and polyarticular arthritis, it makes me just wonder, is this a small vessel vasculitis that's driving what's going on here? I need to ponder this a little bit more and think about this as a presenting signature of that. I think it's possible. The description of the lesions is just interesting. Like they're so umbilicated. I've never seen that as a presentation of that. Are there just like RBCs that are accumulating there a ton? I don't know. Robbie, what are your initial impressions on the glomerular overlap? Because off the bat, I need to think about it a little bit more.
I think you're never going to get me to think about six red blood cells any more deeply than the fact that I would just ignore them. No matter what, no matter how many times Kirtan emphasizes it, says it's persistent, it's six red blood cells. I tell you, the sheer number of people who have six red blood cells is like me right now, and I don't have a problem with that, I don't think. So I'm going to ignore that because I think that's exactly what I would do in real life, especially when the patient doesn't have hypertension, doesn't have proteinuria. I think it's probably much more, and realistically speaking, signal than noise. And statistically speaking, I'm probably going to be right in this circumstance. I'm probably going to have to reflect on it and refine tune that assessment. But I don't think I think the point of these is to be authentic to real life. So I wouldn't make much of it, honestly. And I think that, the whole point of these cases is to try to plot out the journey of where we're going. And the more and more difficulty you have finding an infection, the more and more you start to ask yourself, is this a non-infectious category? Especially when you hear buzzwords like, oh, could this be paniculitis, which can be infectious, but that's unusual, and especially when you hear words like vascular, which certainly are vasculitic in nature. But I think that, if you have a patient with diabetes who has an acute syndrome, we're talking about days or weeks with a neutrophilic leukocytosis that's worsening and thrombocytosis, you really, really have to ask yourself, what infections are you missing? So I think this go around, I'd get repeat blood cultures, retap the joint, really maintain vigilance on the fact that you cannot miss an infection. And it would be premature now, I think, to start to think about what kind of non-infectious considerations could do this when the patient hasn't received a drop of antibiotics and has a white count of 23,000, a platelet of 702, and is diabetic and poorly controlled. Um, but I think what's really interesting is to realize that the exposure history here is very minimal. This person seems to be kind of living a lifestyle that doesn't particularly expose him to many infections. Um, to many exogenous infections. So you might think like, can you get household exposures that can do this? And I think one thing to keep in mind is the possibility of an infection we've discussed a long time ago on VMR called rat bite fever. And I say this because he's staying at home and he may not have noticed a rat bite, but that characteristically causes a really bad polyarthritis and a rash. And the rash tends to be actually vasculitic in nature. So for me, I'm reiterating the importance of treating this patient like an infection until proven otherwise and reassessing the data. I think it's too soon. This case is too hectic to jump to autoimmune, even though it's tempting with the words from dermatology like paniculitis or vasculitis. But I think you have to always make sure that your journey to the answer, even if you get the right answer, your journey to the answer is independent of the actual answer. And I think an infection here looms large in most people with a syndrome like this. Kirtan, Mike, to you, my friend. What do you have next?
Perfect. Sure. So I will give you the biopsy findings and I will give you the CT scan. So this time, since this person has very profound swelling over the lateral aspect of the left wrist, we were more concerned that is this a pyogenic infection that we missed? And as you guys said, the patient was promptly started on vancomycin, ceftriaxone, so on. And the orthopedics team evaluated this joint and they said we would like to get the stat CT scan before we make any further progress. So the CT scan of the left wrist is obtained and it shows that there is soft tissue collection which is irregular in shape, measuring 2.7 by 4.8 centimeter in AP and transverse dimension. There is minimal peripheral enhancement which is more accentuated on the lateral aspect, and soft tissue collection appears to minimally extend into the radiocarpal joint and along the thinner soft tissues. So they were very concerned. They immediately took this patient to the OR. They were thinking that this foci of infection or abscess is the reason why he's looking so sick and why he has so much neutrophilia and thrombocytosis. So in the OR, they drained this space, like drained this abscess. And again, the analysis, staining, everything is negative. They couldn't find anything growing from that. And at this point in time, we also sent urine histo, serum blasto, both of which were negative. And yes, patient was from Chicago itself, has never been to any other place and no pets at home. Meanwhile, what about the rheumatologic workup? So as you, Rabih, said that UA of 6 RBCs per high power field is not going to trick you, but the repeat UA showed 40 RBCs per high power field. And this we are talking about in a gentleman who was never catheterized. We never put a catheter in there. So it was a clean catch sample and it showed 40 RBCs. The creatinine is hanging in there. It is still steady. Protein was slightly there. And I think it was microalbuminuria, so barely there, not very crazy. Serum albumin was always normal. ANA was obtained, ANCA was obtained, both of them unremarkable. Complement levels C3, C4, negative. Cryoglobulins were obtained, negative. And we also got the biopsy at this point in time, and biopsy showed cutaneous leukocytoclastic vasculitis. And dermatology said that the reason why we never saw any kind of purpura, any petechia, is because this rash is bullous leukocytoclastic vasculitis, which tends to present on the peripheral regions of the body, and it will mimic any other kind of bullous disorder like bullous pemphigoid. It can mimic bullous diabeticorum, all those things. So, but in this case, the biopsy showed bullous leukocytoclastic vasculitis. And I will stop there.
Wow, this is a great case. uh, I think my impressions are and my concerns are still where yours were, Robbie. Like it's great we see this vasculitis, but like where is it coming from? I don't know. I feel like there are two paths forward for this guy. He gets like very immunosuppressed after this, and his limbs start falling off because we were wrong because he has an infection, or we're right. So I think we still need to consider all of the infections. And I was thinking again about the heart. The rheumatoid factor was negative. Someone brought up in the chat, Jazz, infectious induced GN. Usually with that, you see hypocomplementemia, which we're not seeing here, but I don't know the sensitivity of that. I feel like just because you can't see reactive vasculitis from any sort of endocarditis that's infected, we probably should still take a look at the heart valves and make sure we're not missing something. And if we do see something, then we could think about culture negative endocarditis DDX a little bit harder. But all that to say, I think if the suspicion is high, we're seeing these, joints involved, reactive vasculitis. I'm not sure that the TTE would even be enough to kind of dissuade us out of that hypothesis, just because you can have very small vegetations that are missed on TTE. But yeah, I'm going to come up with some microbiologic tests, Robbie, while you finish the discussion. And then I think I'm assuming the final diagnosis comes after this. So I want to ponder kind of what we're going to send, and then I'll review when you're done talking.
Yeah, that sounds like a good plan. I'm very intrigued by this case because I think you're starting to get momentum to the disease having a vascular fingerprint, and I think ask yourself what kind of vascular disease has such a prominent manifestation in the extra-articular apparatus, in the joints and the articular tissue, and I think that's a fascinating overlap. At the end of the day, now that you have hematuria and proteinuria, you have no structural cause for the hematuria and proteinuria, you might start to make progress towards this being a glomerular disease, especially when you have vasculitis outside the glomerulus. And I think that would help you make even more progress is if you spin the urine and you see that there are dysmorphic red blood cells, in which case you can actually make the very narrow problem representation that this is a glomerulonephritis, um, with systemic features, including on the skin. And the value of complements here is through the roof, because most normal complementemic GN is non-infectious. If you ask yourself like what the value of complement is, complement the normal complementemic glomerulonephritis is really three things: is posse-immune GN, IgA vasculitis, and anti-GBM disease. Infection-associated glomerulonephritis is almost always hypocomplementemic. And so the dilemma in this situation are the complements normal now, and will be below normal in the future. But if you take them at their face value, you really can start to say, okay, this is normal complementemic. It means that the probability of infection is lower and lower and lower. So I think what I would do to sort of make progress towards non-infectious considerations is most GN is non-infectious, and certainly the vast majority of most normal complementemic GM is non-infectious. So I would probably ask renal to spin the urine and to see if the complements were persistently and stubbornly normal, in which case I think that would help us tremendously. And so you ask yourself, okay, this is GN, but if this is GN, it's not just any old GN. This is explosive, hyper acute onset glomerulonephritis in the context of a neutrophilic leukocytosis. And so you ask yourself, okay, well, what kind of GN begins explosively? well, maybe it isn't explosive. Maybe there's an underlying vulnerability for that for the glomerular disease, and something triggered it, and that's where IgA vasculitis is really important. In fact, Kirtan himself presented a case of Still's disease in a patient who likely also had underlying IgA vasculitis, and the urine was nothing but distracting us from the core issue that the patient had Still's disease. And so you might find yourself in a similar situation here. So I think you were starting to get a little bit of momentum to say, what's up with the kidney? Um, and is this actually a vascular disease with overlap in the extra-articular space? And I think you might ask yourself, how do you, well, yeah, I know, Andrew, you've thought about the microbiological ways to make progress, so maybe I can hand the mic to you to see what you've come up with.
Yeah, I was gonna say I don't know if we've gotten like the silver stains from the tissue still, but I'd be doing that, and I think just the regular culture negative endocarditis workup, like all the Ellas,
Yeah.
like Bartonella, Coxiella, just making sure. But I feel like this hypothesis of this being autoimmune is certainly reasonable. Just following that checklist before we immunosuppress the
Yeah.
patient will be important. I think the idea of like auto-inflammatory process is interesting. I don't know if Kurtal will be presenting that same exact thing as Still's IgA again, but autoinflammatory diseases, one of the kind of characteristic findings you can see is just sterile pus in multiple different sites, like
Yeah.
osteitis, just on the skin, in terms of pustules. So that's an interesting thought, but I have no idea where this is going to land, and I can't wait to learn from Kurtan.
Perfect. I think you guys all got it. So it's going to be very easy to explain to you what next happened. But maybe I can quickly ask, like maybe 30-second response from both Rabi and Andrew, that if you guys had to describe this fluid collection which you saw in the wrist, like is there any way you could link it to the initial infections you were suspecting or any autoimmune diseases? Because that part is a little bit unusual, right? That fluid collection or abscess rather than the arthritis itself. So anything, any like buzzword that comes in your mind for that?
Uh, is like aseptic abscess syndrome, something like that? That's the first thing that comes to mind for me. Robbie, what do you think?
I think I will tell you that in actually just last week I had a patient who had septic arthritis who had a soft tissue abscess next to it. I think so. The question is, if it's culture negative, does that change the possibility that there's infection? I would say the answer is probably no. That I think I would what I would call this is a culture negative, neutrophilic, probably presumably neutrophilic since the wrist was neutrophilic response. In which case, I think that opens up the possibility of culture negative infections. Like, would I be surprised if there's blasto in the joint and then that's tissue, but we couldn't find it? And I actually had a case of blasto and sporothics just like this, where the patient actually got a TNF inhibitor for an ultimate diagnosis of PAPA or PASH, one of the two, and then ultimately the TNF inhibitor caused them to grow out sporotrichosis. So culture negative, and then of course now remember the seed that you have to plant in that case of oligoarthritis is spondyloarthropathies. And the world of spondyloarthropathies isn't just the surface ones, the ones that we commonly talk about, ankylosing spondylitis, reactive arthritis, IBD related arthritis, and psoriatic disease. There's a whole variety of secondary ones, including the ones I just mentioned, PAPA and PASH. And then you won't be surprised that pyoderma gangrenosum, Sweet syndrome, Behçet's disease, um, and even maybe you can make the argument that relapsing polychondritis and vexus all do this behavior where they cause a very aggressive neutrophilic culture negative phenomenon. And so the world of spondyloarthropathies and the world of neutrophilia have a very, very prominent overlap. So I would start to think of those things, but in a poorly controlled patient with diabetes we don't have a CT chest of, I think you have to be very careful and not miss a granulomatous organism. But yes, that category I think is, including aseptic abscess, is totally up for grabs now.
Perfect. So let me tell you guys how it happened. And this case perfectly exemplifies the curse of extensive testing, that more you test, more things you will uncover, and more you will have to explain that what just happened. Like if they had done the right thing on the first occasion, things would have been easy. So how I come to know this patient. So this was during my second admission. That first admission, as I said, he came, They send him home on prednisone. He comes back, and now I was in rheumatology, and this was actually my first rheumatology service. I see this patient, and in the morning I was in the clinic. So we get the consults throughout the day, and I am reviewing the chart. I didn't get a chance to see the patient yet, but I see the ortho note saying that this person has this stuff in the left aspect of wrist with extension into the radiocarpal joint. So I was thinking that could this represent tenosynovitis? Because tenosynovitis is the explanation of how you can have joint in the inflammation in the surrounding structures rather than the joint itself. And they did say in the operative report finally that they confirmed our suspicion that one of the tendon was also involved. So now you could build a very good story, right? That you have skin lesions, you have tenosynovitis, you have oligoarthritis, it could be gonococcal infection. So the first thing before even seeing the patient, I tell the primary team through the clinic that, hey, can you get the gonorrhea swab and stuff? So they told me that, yeah, we got it. It's negative. I was like, just like you guys said, that you got it from urine. Let's get from the throat and rectum. So they start getting that process in, they start getting from the throat and rectum. Now, at this point in time, when I finally go and saw the patient, again, my thought process was confounded that I was expecting pustular lesions or vesicular lesions, and now I see violaceous lesion, which looks like LCV, and eventually it is confirmed LCV. And then the UA shows this blood, which is again confounding our thought process, right? And at one point in time, there was concern that could this be, because gonorrhea didn't come back right away, right? On the day one, we were thinking, could this be systemic IgA vasculitis, which presented with the arthritis and now is causing the rash. But then the tenosynovitis part wouldn't fit well with the IgA vasculitis, right? And then what Rabih said, that we are also thinking that could this be spondyloarthropathy, because oligoarthritis in a young person, you always got to worry about spondyloarthritis. So we got the scans of their like sacrum, and it did show enthesopathy, surprisingly. Like there was symmetric, very prominent enthesopathy, and patient down the line also complained of back pain. So you start wondering, what is this? And we do know that ankylosing spondylitis can also cause IgA vasculitis. It's a very well-established association. But then, as Rabih said, that people can have reactive arthritis from gonorrhea chlamydia, which can also cause enthesopathy, right? So what happened was down the line, eventually the urine gonorrhea chlamydia was negative again, but the throat one, which I had sent, came back positive. And then and then Rheum was like, why did this happen? We were thinking this is IgA, and now Kirsten, you got the gonorrhea and you confounded our thinking. I was like, this is what happens when you keep on testing people more and more. And then what about enthesopathy, right? So we had to link it with gonorrhea itself. And now here is the final surprising part, that gonorrhea can cause vasculitis, like findings, but pure vasculitis from gonococci is very unusual. And furthermore, on immunofluorescence of these skin findings, it showed IgA vasculitis, which has never been described in gonorrhea. So gonorrhea is known to cause sometimes just simple, plain hypersensitivity kind of LCV, but not IgA. And strep and other infections are more likely to cause IgA vasculitis. And of course, we got the transthoracic echo, made sure there was nothing in the echo which was doing this, all negative. So I'm curious to hear from you guys that have you seen gonococci causing IgA vasculitis, or was this a rare incident of gonococci triggering the systemic real IgA vasculitis? And then enthesopathy was probably just from reactive arthritis. So that was the cool aspect.
Yeah, absolutely amazing.
Wow.
Andrew, I'll just jump in to reflect, and I'll actually have to leave in like 30 seconds to make
Okay.
it on time because I want you guys to bathe in the beauty of this case. I just want to thank Kirtan for the last two cases because I think yesterday he took us to the deep, dark depths of medicine that he is illuminating almost single-handedly. But today, in contradistinction to that, he's showing us that if you're systematic in your approach, you will get the answer right. And I think yesterday is the gold standard that we're all aiming for, and today shows you that if you don't think linearly and logically and you start to aim for the stars, you may miss something very, very simple along the way. So I can't thank you enough, Kirtan, for the beauty of the combination of your two cases and your decision to present this case today to remind us that most of medicine is common things and a very sneaky presentations of something very common. It was one of the first words Andrew mentioned in his discussion. And so I'm very, very grateful for that. And really want to thank you deeply. And Andrew, you knocked it out of the park. You were stubborn. You didn't want to move past the usual stuff. And I commend you too for filling Reg's shoes. I'm sure he'll be very, very proud. With that, I will make you, Kirtan, the host, okay? And then wish you
Bye,
all a
Robbie.
wonderful day. Thank
Take
you.
care. See you. Good to discuss. Yeah. Wow. No, I agree with all of Robbie's reflections. I think this is a testament to just being systematic is so important for getting to the correct diagnosis just very quickly. And like understanding your tests too. And people who listen to my own podcast know my love for the methylmalonic acid test for B12 deficiency. It's like if you want to catch B12 deficiency and you have a very high pretest probability for it, you need to send the better test, the methylmalonic acids. If you want to catch disseminated gonococcal infection, you need to send all of the swabs. So I really like that teaching, Kurtan. Thanks so much for bringing it. And yeah, I think intern year me definitely would have landed on IgA vasculitis and done this. And then PGY3 me, having seen someone get immunosuppressed with occult amoebiasis and his face started like necrosing off, it makes me much more hesitant to kind of land on non-infectious diagnoses now. And I think this is a perfect case example of that. Kurtzad, where did you have any final comments on that vasculitis finding? Is this like a case reportable thing? Like, what were your final teaching points for us?
Perfect. So no, firstly, I wanted to say that kudos to you guys. You guys got it. Even in the chat, like Jasdev, Yusuf, and Mary, Ethan, all of them mentioned very early on that how this could be gonococcal infection, and you guys were right on the money. And same for the Andrew, he mentioned within the first thing like staph, strep, and gonococci are the first thoughts which should cross your mind. So I think my only takeaway from this case is that the first time when they sent the patient on prednisone, so as Andrew was also hesitant that that was probably a overkill, that's what also I thought, that I was not part of that team because this is the second time when I was part of this team. So I also wondered that just because somebody has a little bit high uric acid, and we do know that you don't see the crystals in the fluid always, and you sometimes have to go by the hunch, but giving prednisone in somebody who had normal kidney function was a little bit too much. They could have given NSAIDs and then see how patient does, because NSAIDs also work well for gout. You don't have to go for urate lowering therapy on day one or something, right? So I think that would have been good enough. But in retrospect, what happened, that is what gave me another clue finally when I came to see, because now this person has this abscess in the left wrist, and that was my first reflex thought that this is kind of like buzzword, right? I was like, hey, this could be tenosynovitis, and then it fits perfectly the gonococci. And again, at that point in time, I hadn't seen the skin lesions. If I had seen the skin lesions, maybe I would have confused and I would have landed on IgA vasculitis and something like that. But it's good that I didn't see the skin lesions initially, and I was like, okay, this skin lesion must be pustular. This joint must be tenosynovitis. And that's why I told the team to get the gonorrhea chlamydia before even we get a chance to round. So that finally when it came back, there was no worries about it, right? But then I do agree with this part that I'm not sure how to tie in the IgA vasculitis part, because I tried to look at the literature, I tried to comb through the books, and they do say that gonococci is kind of a great mimicker. It can also cause tons of skin lesions, but pure biopsy proven IgA vasculitis, it has not been documented probably. And I was not able to find the good evidence for it. So I'm not sure what to make of that. Maybe we will see him in the clinic. If the skin lesions have completely resolved, then maybe we would say that, well, it looks like gonococci did it. But if the skin lesions are still persistent, then maybe we have to think that was this gonococci which came and triggered the systemic IgA vasculitis and then went away. And now we are left with the vasculitis. So it would be interesting to see his joint symptoms. That now let's say if he comes and he has a new effusion in the ankle joint or something, then that would be interesting that this could be systemic vasculitis. But as of now, I think as Rabih said, that it looks like a straightforward case of disseminated gonococcal infection, which ended up causing bullous leukocytoclastic vasculitis and enthesopathy through reactive arthritis mechanism.
And Kurtzad, did the blood cultures ever flip positive?
No, never. Still never. But
Interesting.
I think you are right that what I remember is that when they tapped the right knee on the second admission, I think on day 4, it did grow gonorrhea. It did say 1+ growth of gonorrhea from the knee joint itself. So we have good evidence that even the knee joint was not like vasculitic, it was from gonorrhea itself.
Got it. Okay. Yeah, I asked because the one time I've seen this in real life was literally just last week through a colleague was showing me photos of disseminated gonorrhea, which is why I brought it up when you pulled up the photos of the rash. It looked very similar. I don't think it was quite as umbilicated, but it looked very similar. And the blood cultures in that case were quite positive. So I guess just another takeaway, if you're trying to broaden your nets, again, a high suspicion for systemic infection with that original leukocytosis, just sending that blood culture, just part of your kind of like wide net of infection. Maybe it could have caught gonorrhea if it was a little bit higher grade of an infection, like in the one I saw last week. But in this case, it sounds like the hypothesis maybe this was all, not all, but mostly kind of like a reactive rheumatologic phenomenon to this kind of more distant past infection. Super interesting hypothesis. Love it so much.
Yes.
Kurtan, a pleasure, everybody. A pleasure. Have a great weekend. Good to see you. Take care.